We talked yesterday a lot about malignant or pre-malignant pathology. This is not about that. This is about what you might find in an esophagus which might not be pathologic. And you might say, well, why did you do on day one? Why did you do cancer? And on day two, are you doing benign? And I think that that is because we recognize that this stuff is about decision-making, and the first stuff is about preventing patients coming back with cancer, and which of those is more important? Well, I think there's a huge drive to prevent patients coming back with cancer. Therefore, we focus more on cancer and put it right front and center. But you could have done this yesterday, no issue. So we're going to cover esophagitis. We're going to cover Barrett's esophagus. We're going to cover later in the day atrophic gastritis and intestinal metaplasia. We're going to talk about gastric polyps. We're going to talk about what Roland just asked about when or when not to resect gastric polyps. And yesterday we covered duodenal polyps. Incidental findings in the duodenum we could open up a discussion on, but we are not covering that specifically. So esophagitis, let's make it a bit interactive because, you know, we're all a bit like cobwebby right now, including me. So Los Angeles grade of classification of GIRD standard. Do you find that useful? Do you use it in your clinical practice? Yeah. Is it common sense, or is it something that you think requires an in-depth understanding?
It's quite common sense.
Yeah, I think all good classification systems that work well are based around something logical and common sense. And this one definitely is. So on the screen, you see the grades A to D of the Los Angeles classification of, as the Americans call it, GIRD, and as we call it, gastroesophageal reflux, or GORD, I guess. And yeah, it's quite simple, isn't it? But let's just do a little bit of formalize on Barrett's, and this will talk about the classification. So I find this picture is very commonly shown, and I find it relatively useless. This one I find much more useful. Thanks, PDM, for finding this and putting it in here. So, John, you also drew this on a whiteboard a bit yesterday, but I do find that this really does nail what you need to write down. It is, I have to say, it is very difficult measuring Barrett's esophagus. It's not something that's simple. I think it's done very badly in general. Alex was talking to me yesterday about, do you do on insertion or do you do on pullback? Because, yeah, the lengths are different. I think all these things are in the mix and all these things are in play. But, of course, what we are aiming for is at least a bit of standardization, right? We are not saying that the precise point, 0.1 of a centimeter is particularly relevant. We are talking about standardizing our practice so that we, at least if Tamaz does an endoscopy and I do an endoscopy, that we are within a centimeter or two of each other. But we are not looking for exact precision. And so how do we do this? Well, first you have to consider the hiatus hernia, the hiatal hernia aspect, and that means you need to find where the diaphragm is. Of course, this you see, but we'll maybe start in the middle, because the most easy thing to find is the top of the gastric folds, right? Or the palisading vessels. So that's, and we'll do some of this, really will nail this. I'm sure we have a patient with Barrett's today. So can someone remind me? We have 2 patients with Barrett's today, so we will go through very clearly the measurement of Barrett's in those patients to really nail that down. But you need to find the top of the gastric folds, because the Z line in Barrett's is not the top of the gastric folds. That is almost the definition of Barrett's, right? That the Z line migrates up the esophagus. So the Z line was the Z line, that is the squamo-columnar junction, the junction between the 2 types of mucosa, and in Barrett's, that migrates up the esophagus, right? So your normal esophagus, the Z line, and the top of the gastric folds are in the same place. In Barrett's, the Z line migrates. So often I find people saying, oh yeah, the Z line's at this, and you're like, what are you talking about? So this already means that the nomenclature is mixed up, right? And you look at that, and C3, the problem is not so much that we care really what people are measuring, but it puts the patient in a totally different risk category, right? So C0, what is here, C0M4, is a totally different risk category to C3M6, right? These are very, very different management, different surveillance intervals, patients getting a whole load of over-treatment if you mess up this measurement. And also, it's very important for when you standardize between procedures. So we need to let sufficient time. We need to spend at least a minute per centimeter segment of Barrett's. Photo document. And this is a nice diagram where they've kind of said, okay, here is our C extent, here is our M extent, here, centimeter, whatever, we're going to take 4, then 2 centimeters above, another 4, and then 2 centimeters above, okay, there's only a little tongue, we're only going to take 1 biopsy. I think that's a nice way to do. And it is my practice, and it should be yours, to biopsy anything suspicious first, separately from the Seattle protocol, and put it in a separate pot. Plastic Barrett's, well, you can do RFA, you can do APC, you can do EMR, you can do resection. We have got many examples of what you can do with Barrett's esophagus on GIEQs, and we're not going to go into it here. You need to refer it to someone. It needs to be someone who's doing a lot of it and doing a lot of therapy. Right. Take-home points before we go to the live room. It's not easy to assess Barrett's esophagus. I think we can surmise that. I think we all know that. You must use all of your tools. You must take some time. The more Barrett's, the more time. Take lots of pictures. And if possible, it is useful to take video of Barrett's, especially if you get unexpected biopsy findings and you need to go back and look. Use a standardized biopsy protocol if you see nothing, but focus your biopsies first if you see something. Avoid sampling inflammation because you are potentially going to subject the patient to over-treatment. And if dysplastic, refer to someone who's doing this all the time. Thank you very much for listening to this.